Hello guys, a warm welcome to all of you. Now the NEET-PG exam is done and dusted, and finally the NEET-PG exam happened and it is over. Concerned with the physiology here, I have seen the questions guys, and I personally like them very much because they are highly conceptual. More importantly, except two questions, remaining questions came from the very well-known familiar areas. So with that small introduction, we have the exam happened in two sessions. So separately, we are going to discuss those questions asked on the session basis. So first it is about the session 1 and the physiology questions. As with our discussion always, I will show you the question in the beginning. Please try to see the answer. Whatever you have marked, just have that in mind. Let us have a discussion and whether we see you marked correctly or not. And I'm sure majority of you should have marked the correct option. Yeah. Now the first question. In order to prevent polyspermy, this is what I told you guys. This is the question, this polyspermy, a brand new question here asked for the first time in physiology. What is the reaction in the zona pellucida of oocyte after fertilization? Is it acrosomal reaction? Many of you are familiar acrosomal reaction or cortical reaction or something to do with membrane potential of the oocyte. It has got nothing to do with membrane potentials. Polyspermy, nothing to do with membrane potentials and no relationship to acrosomal reaction. What is the best answer here, guys? The answer for the question is cortical reaction. And let me remind you, these type of questions have the high probability to get repeated again. So you need to understand what is cortical reaction. A beautiful diagram I will show you first. Look here now. This is sperm waiting to penetrate the ovum or the egg here. In this egg cytoplasm, we are clearly seeing something called as cortical granules. Yes, sir. Inside this cortical granules, certain things are present. First observation. Second, these cortical granules are actually fusing with the membrane and they are going to release out something. Exocytosis of something is going to happen. What I told you so far, please be with me. Enzyme-filled vesicles called cortical granules are seen where in the egg cytoplasm. Most important thing, for this cortical granules content to be released out for all exocytosis, I taught you an important ion is needed. What is that ions are? Exocytosis. Can you answer me? Which ion? Calcium. Excellent. There should be increase in intracellular calcium. Then only exocytosis of these granules happen. Inside these granules, you see a lot of hydrolytic enzymes. Once they are released, they are going to modify something. They are going to modify this zona pellucida protein ZP2 and forming something called as ZPF. So zona pellucida 2 protein is going to become now ZPF, which is a tight barrier. And it is this tight barrier that prevents polyspermy. So only one sperm can enter. Immediately after entering, intracellular calcium rises. This cortical granules exocytosis of hydrolytic enzymes, which is going to modify our zona pellucida ZP2 and form ZPF. This prevents polyspermy. Even more important, beautiful understanding. Now look at this diagram, guys. This entire sequence of reaction is called cortical reaction because it is the release of cortical granules. Now look into this diagram. A sperm is actually entering. It goes inside. Lot of cortical reactions happen. Now this is that barrier I told you, ZPF. There is a tight barrier now so that further sperms, another sperm cannot enter. 1:1. So one form fusing with one egg. What is this reaction? Cortical reaction, release of cortical granules. Now, look into the question. We have had a very important discussion. In order to prevent polyspermy, what is the reaction in the zona pellucida? It is going to become ZPF. What is this reaction called? Cortical reaction. An important MCQ, a brand new MCQ. We have had a very beautiful discussion for the cortical reaction. Next question. Concerned with taste. Who answered this question correctly? It is also a brand new question. They asked about sour taste is mediated by. And let me tell you guys, metabolic receptor, many students told this option was there. T1R1 was there. T1R3 was also there. Concerned with option A, a TRP channel was mentioned, but exactly that number, we are not sure, but the TRP channel is mentioned. So let me tell you the best answer for this question. Sour taste is actually mediated by a TRP channel. TRP channels play a lot of role in so many important things. We discussed them with temperature sensing. Now here concerned with the sour taste. So the answer should be a TRP channel. I am very sure, 100% sure, a TRP channel was actually mentioned in the question. This is what many students told me. So the answer for the question should be that TRP channel. Now a very important discussion. Look very carefully, guys. And what are those important taste sensation? So any good thing, we should always start with the sweet. The next important one is the salt sensation. The third one is actually the one in question, sour sensation. Fourth, many actually don't like. What is that? Bitter. And finally, the recently discovered one, the taste of a tomato, umami taste sensation. The fifth one is umami taste sensation. Now the question proper. Remember, receptors for this taste sensations, a very important table, high yield table. Surely question will be picked from this table in the future. Two group of channels are there, my dear friends. First group is called as a metabotrophic channel receptors. This metabotrophic simply means a G protein coupled receptor. That's all. Metabotrophic means G protein coupled receptor. Second group is ionotrophic. On opening, they leads to influx of ions. That's all. So which all taste have ionotrophic receptor? Salt and sour. Ionotrophic receptor. Remaining three, sweet, bitter, and umami, metabotrophic G protein coupled receptor. The most important take home message, salt sensation and sour taste sensation, ion channel mediated. Remaining three, G protein coupled receptor. Now look very carefully. How to remember this table easily, sir? I told you, ionotrophic ion, sodium is an ion, correct? So epithelial sodium channel, ENAC, ion channel, salt, correct? Sour, acid, remember, H plus, is an ion. This sour taste is also mediated by, remember, these are not definitive, exclusively for sour taste. Even now, when I'm talking to you, so much of research is actually going on to find out that exact channel protein. We have certain candidate receptors. That's what I'm going to tell you here for sour taste. Epithelial sodium channels are involved. HCN channels are involved. TRP channels are involved. That is why we are choosing the answer for this question, TRP channels. Simple. So sodium ion, H plus ion, salt, so. Very easy to remember. Now, bitter means bi. Bi is there. Bi means 2. T2R. It's a G protein coupled receptor. TR stands for taste receptor, my dear friend. Bitter, bi, 2, T2R. So 3 over, salt over, sour over, bitter, bi, T2R. What about sweet, sir? You can remember the taste receptors T1R2, T1R3. What about umami, sir? Remember this umami taste sensation, even first year MBBS university exams, they are asking this question. It is very, very important these days. Umami. Metabotrophic receptor, it is through mGlu-R4. Metabotrophic glutamate, that's why. Metabotrophic. mGlu-R4. Other than that, remember T1R1, T1R3. T1R1, T1R3, umami taste sensation. So this table is very, very, very important. Sour taste is actually the question. It is mediated by TRP channels. And students clearly told me a TRP channel was actually mentioned. The answer for this question definitely should be TRP channel for sour taste sensation. Very important thing. Now, the next question. What are the effects of posterior lesion in Brodmann area 22 in a stroke patient? To answer this question, you need first to know what is this area 22. Second, speech and its abnormality, physiology, pathophysiology, clinical medicine, definitely question is going. That is why for this question, we are going to have a small practical demonstration. Now listen to me very carefully. I am speaking to you guys exclusively. I am using the vocalization power. One area is highly active now. Now you are sitting passively and listening. You are trying to understand what Dr. Krishna Kumar is trying to tell you to make some sense out of it. That's all. I am speaking vocalization. You are listening, you are understanding, you are comprehending the information. So which area is active in me? Which area is more active in you? Very important concept. It is about Wernicke's area. The answer for the question is receptive speech function. Very important discussion. Now look into this picture. 4 important speech area, guys. First, the one that is highly active in me now, Broca's area. Where it is present, sir, every single word is important. Left inferior frontal gyrus. The area is 44, 45. Very important for vocalization. Motor speech area. Remember, motor speech area. Lesion here causes Broca's or non-fluent aphasia. Now, coming to the question proper. The exact wordings in the question you will see here. Wernicke's area. Posterior end superior temporal gyrus, area 22. Excellent, sir. It is the sensory area that is active in you now. You are listening to me. You are understanding. Yes, sir is talking about Wernicke's area. And lesion here causes Wernicke or fluent aphasia. So, reception, understanding, comprehending will be a problem here. So, these two areas are connected by a bidirectional communication pathway. That is our arcuate fasciculus, that connecting one arcuate fasciculus. Lesion here causes conduction aphasia. And finally, the lost area. Now, a small demonstration. Put your video, now we are seeing the audio part, the microphone to a mute. You can only see me. That means through your vision, you are seeing Dr. S. Krishna Kumar. If somebody is asking you who is there in the screen, you can say definitely Dr. Krishna Kumar is sitting here and talking to us. By any chance, if you are seeing me, but you are not able to speak out, this is Dr. S. Krishna Kumar. Where is the problem? Angular gyrus. That means visual information is conveyed to speech areas. Seeing and telling. Showing this in front of you, you can definitely say this is a pen. If you are not able to say this as a pen, you have problem in angular gyrus, and this leads to anomic aphasia. So Broca's, Wernicke's, the connecting arcuate fasciculus, and finally the angular gyrus. This question is about the Wernicke's area. So reception error will be there. So what is the answer for this question? Yes, sir. Posterior lesion, Brodmann area 22, receptive speech function. So the answer is option A. This is the important discussion for the speech areas. All right, guys. Now let's move into the next question. Incorrect again about iron absorption. See, iron, its metabolism, physiology, biochemistry, medicine, hemochromatosis. Very, very important area, guys. Incorrect. The question is about the incorrect statement. Look into option A. Ferrireductase converts Fe2 plus to Fe3 plus. So that is the incorrect statement. So option A itself we can clearly see. Now, very important discussion. It is about the absorption of iron, where it happens in the GI tract, mucosal cell. So a mucosal cell is shown here. This is the lumen part. Following absorption, it have to go to the blood side. So this blood side is the basolateral part. Blood means B, basolateral. Now, first and foremost question, what is the dietary source of iron availability, sir? It is always the ferric form, Fe3+, which is converted by this enzyme ferric reductase to the ferrous form, Fe2+. So 2 di, that means a divalent metal transporter is needed. So what is this DMT? Divalent metal transporter that is moving inside this mucosal cell, the ferrous form. One other source of this iron, what is that, sir? The breakdown product of heme. So this heme also contribute to inside the cell, the ferrous form. Now, the mucosal cell is having the iron in ferrous form. We need to store it for future use. For RBC development, we need this. So you need to store this. For storage, the storage form is ferritin. Excellent, sir. So inside this cell, this ferrous is converted to the ferric form and stored. What is the storage form? Ferritin. After storage, what are we going to do with this remaining iron, this ferrous? It is now converted, very important. From the basolateral side, it will be transported out with the help of this channel protein, ferroportin. Where ferroportin is present? Near the blood side, basolateral. So this ferrous is now coming with the help of a very important enzyme which is called hafastine. So this ferrous form will be converted to ferric form. So in the blood, it will be transported. So that transport is with the help of transferrin. So in the blood, it is now combining with the transferrin and transported. Very simple logic, guys. In the mucosal cell, whichever iron that is coming inside will be stored as ferritin. Remaining will be transported out into the blood, where with the help of hafastine, ferrous form is converted to ferric form, combining with the transferrin and transported in the blood. So what is this question about? This question is about a ferric reductase which converts the ferric form to the ferrous form. So, but what is actually given? You can clearly see in this. It is the ferric reductase that convert ulta, opposite they have given. So that is the incorrect statement. Yes, this is about absorption of iron. Next question. In type 2 diabetes mellitus patient, serum insulin levels are found to be raised. Is advised to exercise to improve insulin resistance. Which of the following glucose transporter will help to improve insulin resistance after exercise? Remember, guys, this was discussed previously. Glucose transporters, sure shot MCQ, and that too, if it is about insulin, it is always about GLUT4. Very important. So what were the questions asked previously? Which are all the insulin dependent sites for glucose uptake? Can you help me? Answer me. Yes, I'm hearing it correctly from you. There are 3 locations, sir. Insulin dependent. And what are these areas? Obviously, the first and foremost is heart. Second is this muscle. What is this muscle, sir? It is skeletal muscle. What is third, sir? This tissue, adipose tissue. So with the help of insulin, we are going to upregulate a channel protein. What is this channel protein, sir? It is none other but our glucose transporter 4, which moves all the glucose molecules inside these 3 locations. So insulin comes, upregulates GLUT4 in heart, muscle, adipose tissue. So all the glucose from the blood will move into these 3 locations, thereby decreasing blood glucose level. Now, this is not the utmost understanding here, guys. What I eventually want here, apart from solving this MCQ, India is the diabetic capital, we all know. Definitely in all of our homes, some people will be there as diabetic. So whenever you see them next time, you advise them go for a walking for 30 minutes in a day. Very easy. Walking, either in the morning or evening. Why, sir? Because exercise itself is shown to upregulate glucose transporter 4? This was asked. In the next session, maybe they will ask you the molecular mechanism, AMPA kinase. What is this AMPA kinase, sir? Adenosine monophosphate activated kinase. So exercise is going to activate this AMPA kinase pathway, which will upregulate GLUT4. Remember, this action of exercise is independent of insulin. Independent of insulin, you can upregulate GLUT4. No need of insulin. This exercise itself helps in upregulating GLUT4. That is why whenever you see any people having diabetes mellitus, please ask them to go for a walking for minimum 30 minutes, because this exercise helps in upregulating GLUT4, thereby help in reducing blood glucose. Very important thing. Next. Patient presented with chronic tingling sensation in the forearm. Neurological examination was done. Which of the following receptors are responsible for this? In a way, these type of lengthy scenario-based question are something like touching your nose like this. See, we all have this familiar saying, na? Rather than touching nose like this, they are touching the nose like this. Very, very difficult, right? Which of the following receptor is responsible for fast vibration? That is the question. Remember, Pacinian corpuscle is very important for fast vibration. So by this time, you yourself realized this glucose transporters, this touch receptors, they will always come in your entrance exam. Very important. These touch receptors, how many are there? 4 named receptors. See, we have 4 important receptors. First, second, third, fourth. What are they? Meissner corpuscle, Merkel cells, Pacinian corpuscle, Ruffini's endings. Just look into the picture and tell me, guys, which are all superficial and which are all deep. Yes, we are clearly seeing the first and the second are superficial. The third and the fourth are deep in location. Now, very important table, sure shot MCQ, guys. Look into this Meissner corpuscle. I told you this Meissner corpuscle is superficial. Meissner corpuscle, always remember ant. Meissner corpuscle. Suppose in our skin, if an ant is crawling, a special type of discriminatory touch, the small strokes this ant leg is making in our skin, such a minute decoding we can do with the help of superficial Meissner corpuscle. That is the meaning of stroking. That is the meaning of discriminatory touch. An ant crawling in our skin. That's next. Merkel cells. Remember, blind people, they always read with the help of Braille reading. Merkel cell, blind people, Braille reading. Pacinian corpuscle is very, very, very deep. They respond to pressure. Not only that, fast vibration. We do vibration sense with the help of a vibrating tuning fork. That vibration, fast vibration, is by Pacinian corpuscle. And finally, Ruffini's endings detect skin stretch. Not only that, they are found in the joint capsule region. They are also the joint capsule receptor, Ruffini's ending. So these are the 4 touch receptors. Remember, Pacinian is very important for fast vibration. And finally, in response to their adaptation, anything that is ending with the corpuscle are rapidly adapting. That means what? Our Meissner corpuscle and the Pacinian corpuscle are rapidly adapting. So remaining 2 are slowly adapting. Corpuscles are rapidly adapting. Now you can clearly understand touch receptor names, where they are located, superficial or deep, what is their function, which one is rapidly adapting, which one is slowly adapting. Never forget, fast vibration, always Pacinian corpuscle. Simple. Next question. Patient came with a punctured wound on left chest wall. Radiological investigations confirmed pneumothorax. Keyword. Which of the following is correct? Again, another very familiar question from the respiratory physiology. This is what I told you, guys. Questions are widely segregated in physiology this time, not on one specific topic. Cardiovascular, respiratory, endocrine, reproductive, neuro, general physiology, cellular physiology, from everywhere question came. So pneumothorax. What should be the answer here? Again, a very familiar diagram. Lung volume decrease, thoracic volume increase is the answer. Why? We have discussed so many times on this important diagram. Comparing complaints of three important structures. Comparison of complaints. Complaints of lung, which one? B graph. This is complaints of lung. Chest wall, which one? A graph. This is chest wall. Combined lung and chest wall, which one? The C graph. Very important. So B is the complaints of lung, A is the chest wall, and C is the combination of both. Now we are clearly seeing there are two opposing forces. There are two opposing forces. What are they? The first one, chest wall. The second one, lung. Chest wall is trying to expand. Lung is trying to collapse. So these two opposing forces come to equilibrium at one point. That is our functional residual capacity. You can see in this diagram, this one. These two opposing forces are balanced out at the functional residual capacity. By any chance, if these opposing forces have some problem, that means one will clearly win, other will lose. Chest wall, tremendous expansion, lung complete collapse. When will you see pneumothorax? During pneumothorax, whenever you see a patient with pneumothorax, there is full expansion of chest wall and complete collapse of lung. So lung collapse, lung volume will decrease. Chest wall expansion, thoracic volume will increase. So pneumothorax, lung volume decrease, chest wall volume increases. That is the importance of this important diagram. Again, asked numerous time years, very, very important area, compliance. Now, a patient who underwent right limb amputation 2 years back now present with severe pain in the limb. Limb is not there amputated, but still he is feeling pain. That means it's a phantom limb pain. On radiological examination, what is the finding seen? Any idea? This also we have discussed. This is the concept of cortical plasticity. Just pause for a moment and look at me, guys. Very, very, very important discussion. The answer is option B. Projection of adjacent fibers to overlap the left somatosensory. See, it is the right limb because it is always the contralateral representation. Left somatosensory cortex. First and foremost, look into this diagram. What is this law of projection, sir? Very simple concept, guys. This is my thumb. If someone is touching my thumb, the information goes all the way here, cross and comes left side. What my sensory cortex will do? It will project that information all the way down towards the receptor location, so that I can say someone is touching my thumb. Closing my eyes, you guys are touching my thumb. The information is traveling, crossing left. The cortex will project that information all the way towards the receptor location. I can clearly say someone is touching my thumb. Now what will happen? Whenever if you remove this thumb for any reason, from the peripheral body part we are removing, but the representation of the thumb is still there in my cortex. You can only remove the peripheral body part. You cannot stripe away the receptor location in my sensory cortex. It will see. You can clearly see now. If any vacant land is there, if nobody is not there, suddenly what will happen? Goat will come inside, cow will come inside, dog will come inside. They all encroach onto that area if nobody is there. In the same token, the remaining areas will occupy now that area previously occupied by the thumb region. So this is called law of projection. This is what? If this thumb is removed, the nearby areas will encroach upon this thumb region. What is this concept called? Cortical plasticity. So even though the limb is missing, the patient is still experiencing pain. That is our phantom limb pain. So what is the answer for this question? Very simple, sir. Right limb amputation. He is having phantom limb pain because projection of adjacent fibers to overlap the left somatosensory cortex. So it is the left somatosensory cortex. We have a very important discussion. This is what I told you. Encroaching. They now come and occupy this thumb region. This is called cortical plasticity, responsible for phantom limb pain. Yes. Next question. A 30-year female went on vacation and fell asleep while sitting in a beach. After some time, she woke with sunburn. Later, when she went back home, she experienced pain while taking warm bath. Which of the following receptor is responsible for this? Again, a very simple question. A non-painful stimulus is now perceived as a painful stimulus. Non-painful thing you are feeling as painful. That means allodynia. It's an innocuous thermal receptor, and here the concept is allodynia. Exactly what is given in the question, if you are not able to understand, you are very familiar with this. Nowadays, people want to get tanned, right? They want to get tanning. It's a fashion statement now. Sunburn. This individual is now lying down on the beach. You will definitely come across in future this theme. What is that theme, sir? One nation, one season. Because of global warming, I fear we'll be able to see this autumn, spring, winter, and all. It is hot, hotter, hottest. So, on a public health note, it's a serious concern, not joke. One nation, one season. So, this individual is having sunburn. So, after a lot of time spending doing nothing, actually, he is lying down and he want to go back and take a bath. Now, that sunburn region, whenever the water, if coming from the shower, if it is hitting that skin, he will definitely feel pain. What is this called as? Allodynia. What is the meaning of allodynia, sir? A non-painful stimulus is experienced as painful. This is the concept of allodynia. Again, we know already, they are asking it in a different way. This is allodynia. Non-painful stimulus is experienced as pain. All right, guys. So far, we have discussed about the questions from session 1. Now, let's move to the questions asked in session 2. So, what were the questions? Again, very simple here. The first question. Arrange the sequence of steps involved in the neuromuscular junction end plate potential. So, which comes first? Calcium, neurotransmitter, sodium influx. So, the answer is very obvious. It should be definitely option A. I'm sure majority of you answered correctly. Calcium comes, acetylcholine will be released. Acetylcholine acts on its nicotinic acetylcholine receptor, which is actually a sodium channel. So to understand this, a very important discussion, guys. This neuromuscular transmission happens at neuromuscular junction, which is a type of a modified synapse. So any synapse will have a presynaptic region, postsynaptic region, and a synaptic cleft. That's all. What is the presynaptic region here? This presynaptic region is the neuron motor action. What is the postsynaptic, sir? It is the muscle. Postsynaptic is the muscle, that is our end plate. So the question contains the word end plate potential. Do you all remember? End plate, postsynaptic muscle. In between these two synaptic cleft. So where will you see the neurotransmitter? Neurotransmitter is always present in the presynaptic region. Stored in the form of vesicles, true. If you want to release this neurotransmitter acetylcholine for all exocytosis, in the first question I told you what you need, calcium. How calcium comes? Through a calcium channel. A voltage-gated calcium channel. Calcium comes inside first step. Acetylcholine comes out second step. This acetylcholine is going to act on this nicotinic acetylcholine receptor underline N. Acetylcholine acting here, what will come inside this? Sodium. So, calcium comes first, acetylcholine will be released, acetylcholine acting on nicotinic acetylcholine receptor leading to influx of sodium. So, the answer for the question is very obvious. Calcium, acetylcholine, sodium influx. Simple. Now, the next question. The resting membrane potential of nerve is minus 70 millivolt. Increased permeability of which ion is responsible for the resting membrane potential? I saw many students confuse this with potassium and chloride. The possibility for chloride as answer is nil. Remember, any question about resting membrane potential, please don't make a mistake in future also. RMP maintenance, RMP generation, totally one and only ion, that is potassium. It has nothing to do with chloride here. If you can argue the value they are giving is -70, -70, -90, doesn't matter. Permeability at rest, the cell is permeable to potassium. The answer for the question is potassium. The theme we have discussed already, resting membrane potential. Consider this cell. Which ion is present more inside? It is obviously our potassium. Intracellular. The same potassium outside the cell, it is always very less. At rest, the cell is only permeable to potassium. Look into the arrow mark. What is this transport processor? High concentration to low concentration. This is a passive process. This is none other but diffusion. So this passive diffusion of which important ions? Potassium ions, is what is responsible for generation of resting membrane potential. Potassium ions moving from inside to outside. Potassium is positive. It is taking lot of positives outside. So inside the negative charges accumulate. This inside negativity is our resting membrane potential. The cause for the resting membrane potential is passive diffusion of potassium ions. Potassium is the answer. Next question. Functioning of thyroid involves transport of iodine from blood to the thyroid follicle. Iodine transported from follicle to colloid later. Which pump or channel is for transport of iodine from follicle to colloid? Which is actually one of the most beautiful question. Hats off to the setter of this question. Very interesting question, I must say. So you should not choose sodium iodide importer here. If you choose that, that is not the answer. Because they are asking iodine from follicle to colloid. The answer is definitely pendrin, option D. So to easily conceptualize this concept, look into this beautiful diagram, guys. Just follow my discussion. This end is the blood, okay. Thyroid follicular cell is shown, okay. Outside this follicle colloid. So look carefully. From blood to this follicle cell, you have sodium iodide importer. That is not the question. They asked from this follicle to the colloid, which is involved. Pendrin is involved. The answer for the question is pendrin. From follicle to the colloid, it is through pendrin. What is this pendrin, sir? It is none other but a special type of iodide chloride antipode. Both are moving in opposite direction. The other name for this channel protein, iodide chloride antipode, is pendrin. Where will you see this pendrin channel protein? Two important locations. First one, obviously, is our thyroid gland. Second one is our inner ear. So two important locations, thyroid gland and inner ear. That is why if the channel protein is mutated, thyroid gland will be affected. The patient will definitely have goiter. Inner ear will be affected. It is sensory neural hearing loss. What is this combination, sir? Mutation of pendrin lead to a very well-known syndrome, that is Pendred syndrome. Goiter plus sensory neural hearing loss, Pendred syndrome. So it is about the pendrin here. The answer is pendrin. Next question. Compensation in metabolic acidosis happens late in kidney. Kidney is always long-term, guys. Be it blood pressure regulation, be it acid-base balance, kidney is always the long-term compensation. The answer is very simple. Because it takes hours to days for kidney to synthesize enzymes that produce ammonium. So the answer for the question is C. How we arrive at this answer? Now look into this discussion. Very simple. Acid-base balance is always about an equation. What is that equation, sir? Metabolic end product, carbon dioxide, react with water. We will get H2CO3. which will split into the H plus ion and bicarbonate. This H plus ion is our prototype acid. This bicarbonate is our prototype base. So how are we going to tackle this acid? The answer is nearby. So the first line of defense is always in the form of buffer. First line is buffer. This happens within a fraction of seconds. Within a fraction of seconds, H plus ion is neutralized by base buffer. Within minutes, second line of defense. Remember, within minutes, body will quickly compensate by throwing out carbon dioxide. Look at me. Breathing. So this breathing should be regulated at the level of lungs to take care of carbon dioxide. And finally, later the compensation, very good effective compensation, which takes hours to days to manifest. Which one's a kidney compensation? Kidney compensation happens late because you need certain enzymes. Synthesizing that enzyme, genetic machineries have to be activated. It takes time. First line buffer happens within seconds. Second line defense for acid-base balance, lung happens within minutes, taking hours, even days to manifest those compensation kidney. That is why we are choosing. The answer for the question is very simple. What is that answer, sir? It takes hours to days for kidney to synthesize enzymes that produce ammonia. So the answer is option C. Yeah. Next question, this discussion we had. Again, cerebellum, very, very favorite topic for all examiners. Patient presented with alcoholic gait, which we see in day-to-day practice. Very common occurrence, right? These days. Someone walking in the road with alcoholic gait, abnormal eye movements after road traffic accident. Which lobe of cerebellum likely affected? This is the lobe that is exclusively concerned with equilibrium. First eye. Second eye, remember, eye movements. Third, most importantly, balance. So equilibrium will be affected, balance will be affected, gait disturbance will be there, eye movements will be affected. For example, vestibulo-ocular reflex, regulated at vestibulocerebellum. These are all components of, or the combination of, this flocculus and nodulus. We call flocculonodular lobe. So the answer for the question is definitely option B. Flocculonodular lobe concerned with equilibrium, eye movements, balance. Solution here, definitely the patient is having nystagmus, gait abnormality. So which lobe is affected? Flocculonodular lobe. These are the questions, guys. These are the important questions that came in this recent NEET-PG 2 sessions. At the end of this discussion, you yourself have clearly realized one or two questions, brand new questions. All the remaining areas, very familiar areas. If you are thorough with these areas, definitely you can clearly answer correctly. I think many of you answered these questions correctly. Physiology these days, other than the routine basic areas, they are targeting the clinical physiology areas like this pendrin, like this flocculonodular lobe. So physiology have to be learned from the clinical point of view, clinical physiology. That is the importance of this discussion. These are a lot of clinical physiology questions, and that is the future also. My good luck and best wishes are always there for you guys. Keep in touch. Good luck and best wishes. Thank you so much.